Okay, so I think we'll get started. Just for all of you in attendance, to record your participation for this activity, it's important to text the activity code number 23056 to phone number 203-442-9435. You should receive a message back that verifies your activity for this to receive a CME credit. So first of all, I want to thank you for attending the first Yale IR Grand Rounds of 2021. Interestingly, one of the few positives of COVID is that we can actually have world-renowned guest speakers with very little logistical issues. Today, I'm really pleased to have with us Dr. Jean-Pierre Pelage as our speaker today. I've known Jean-Pierre for at least 15 years now. I think, if I remember correctly, he had invited me to speak at an embolotherapy meeting back in France, back at the Institut Louis Pasteur. Mm-hmm. I don't know if you remember that, but one of the, I guess, things that I don't know if Jean-Pierre remembers this, but I now have a hobby of collecting coffee table books. And I think that he had taken me all over Paris in order to get me one of these books so that I can have for my, I think it was the first one of my collection. Wow. So anyway, just a little bit about Jean-Pierre. He received his MD degree from the University of Paris back in 1996. He then received a Master of Sciences in Image Processing in 1998 and a PhD in Biomedical Engineering in 2002 at Compiègne University of Technology in Compiègne, France. Now, going through his CV, I actually had to look up the pronunciations, a lot of the words on his CV, because I'm not really good at speaking French. But anyway, afterwards, he became an assistant and associate professor of radiology at the hospital La Reboussière. He was there from 2000 to 2003. And then moved to the hospital Ambroise Paré, where he rose to the level of vice chair of radiology. He then became chair and chief of radiology at Caen University Medical Center in Caen, France in 2011. And he's still there to this time. He's currently professor of radiology at Caen University Medical Center in Normandy. And he's currently vice chief of the Department of Radiology and Nuclear Medicine there, as well as the co-director of the HHT Center, which is something, as you know, we're very interested in at Yale. So Dr. Pelage has been a leader in academic radiology for approximately 2 decades. He was a pioneer and early adopter of uterine fibroid embolization. And back in the early 2000s, he wrote the textbook, along with Jim Spies, who, as many of you know, is the chair of Georgetown on the topic. So he's been a leader in uterine fibroid embolization for now about 2 decades. And he was kind of surprised when I told him that at this institution, there has been some encroachment of this by some vascular surgeons. He's published about 140 peer-reviewed articles, has more than 200 invited lectures worldwide. And today, he's going to be speaking to us about embolization of uterine fibroids and pulmonary AVMs, how to refine your technique from bench to bedside. So with that, Jean-Pierre, welcome.
Thank you, David, for this kind invitation and for the souvenir of 2005 Pasteur Institute. It's a great pleasure for me to be here. I guess that I will share my experience in front of physicians, nurses, technicians, residents. It's a real privilege to be part of your ground rounds, especially the first one of the year, of this special year again. So thank you again, David, for the invitation. The whole idea of this lecture is just to tell you a story, to explain the way we've been working in clinical practice with constant interactions with preclinical and clinical research in order to better understand what we were doing, in order to improve our results, to reduce our complication rates, and to move in the direction of a more standardized technique of embolization. And the two topics that we have decided to cover today are uterine fibroids, with a long story, of course, and more recently, how can you improve your technique to treat pulmonary arterio-venous malformations. These are my financial disclosures that you can find on your website. So as most of you may know, uterine fibroid embolization is a standard technique now. It started with the treatment of postpartum hemorrhage. So embolization in the late 80s became one of the reference treatment for intractable postpartum hemorrhage. And uterine fibroid embolization was discovered as a new indication for arterial embolization for pelvic abnormalities and bleedings. Initially proposed in Lariboisière Hospital, my former institution. I was a resident and fellow at that time. Embolization was offered as an alternative to a risky surgery in women with severe amenorrhea. At that time, thinking of targeting tumors, they were using non-spherical PVA of very small diameters, 150 to 300 microns, with the idea of entering inside the tumor to get a good result. The angiographic endpoint was also quite aggressive, embolization of both uterine arteries until stasis was achieved. So the initial results were quite encouraging in terms of control of bleeding and improvement of pain, but major complications were also reported. Jean-Jacques Merlin, a famous interventional neuroradiologist, one of my mentors, was the one who first described and reported uterine fibroid embolization. He was a pioneer not only in neuroradiology, but also in a number of vascular malformations and pelvic diseases. That's his picture. So we published some early experience with fibroid embolization, both at my place and with a group in the UK, Woody Walker. This was clinical research, and that was the initial experience. But from our experience, we reported at least two major complications. One was related to uterine necrosis, myometrial necrosis or endometrial necrosis, potentially leading to hysterectomy or potentially associated with chronic endometritis of ischemic origin. Second major complication was 2 to 4% risk of definitive amenorrhea, potentially associated with ovarian failure, clearly also as a complication of a potentially too aggressive embolization. So if you look at the anatomy, with the small PVA particles used in a very aggressive way until stasis was achieved, you can obviously occlude these branches supplying the fibroids, but also some normal myometrial and endometrial branches. And you may also enter some of the anastomosis between the uterine artery and the ovarian artery. Stasis means that you were occluding all branches up to the origin of both uterine arteries. So clearly very aggressive technique, but we didn't know at that time. These are a few cases are reported, personal cases, unfortunately. This is a gross specimen of hysterectomy, showing extensive endometrial and extensive myometrial ischemic damage to the uterus and some tiny particles deep inside the uterine wall. Again, 150, 250 non-spherical PVA aggressive endpoint. What were the hypotheses at that time to explain amenorrhea? So for the ovarian, uterine necrosis, it was quite simple, very aggressive, very distal occlusion. Regarding the effect on the hormonal cycle, vascularization of the ovary, that's an anatomical variation, not that frequent. Non-target embolization of the ovaries through the anastomosis, I have demonstrated on the drawing. That was probably the most significant parameter. Endometrial ischemia, potentially associated with synechia, that's another option. Radiation exposure, usually limited. And the age, of course, is also a risk factor in general. These are a few examples of angiography, nicely showing these connections between the distal part of the uterine artery and the ovarian artery with a retrograde filling. And these are, again, specimens of resection. This is an ovary, a personal case, again, with small PVA particles deep inside the ovary, and another case from the literature with the small microspheres in a tube. So non-target tubal and ovarian embolization is an issue. So what was the process to improve, to refine our technique? First, we started clinical studies with obviously an empiric technique of embolization. We were thinking of technical improvement. Two ways to improve. First, back to preclinical evaluation. In fact, we had not conducted any preclinical studies because, as I explained, it was almost discovered by chance as an extension of the use of embolization for bleeding. Preclinical evaluation and then clinical studies with some of the results obtained from the preclinical evaluation. The goal was to achieve favorable clinical outcome, reduce recurrence and complications, and achieve a durable result. So all these parameters being associated with standardization. Can you consistently obtain the same results? So the ideal embolization should target the fibroids, sparing normal tissue, myometrium, endometrium, ovaries, and tubes. That's the initial discussion. From clinical research, we've been able to identify some subgroups with favorable outcomes and some patients with increased risk of complications. As I told you, women older than 45 were at risk of becoming amenorrheic after embolization, but technique was also a parameter, and we wanted to move forward and find a way to reduce this. So back to basic concepts, you have in vitro evaluations. Well, you can use flow models, you can use different methods. We used the Young modulus technique to evaluate compressibility of the particles used. But definitely you will need in vivo evaluations because you want physiological conditions, you want to be able to perform flow-directed embolization and to obtain proofs. Proofs, gold standard is pathology. You want the organs to be explanted, analyzed under the microscope to better understand the extent of necrosis, the location of the particles. So you want an animal model. Animal model suitable to perform uterine artery embolization. So the size should be compatible with the devices used in women. Kind of similar arterial anatomy, even if most of the animals don't have fibroids. You should be able to perform in vivo imaging, so angiography, of course, but also MRI. You should keep the animals in the long term for long-term studies, and you should obtain pathological evaluations. Other requirements, availability in Europe, literature, if existing, and cost. These are the different options we have in most animal labs in France. Mouse, rats, and rabbits were considered too small. Cats and dogs are not very popular in our country because they are pets, so not easy to be used in clinical practice. Monkey is favored mainly by our colleagues from pediatric interventions because of the cost. So we mainly deal with pigs and sheep. We decided to conduct feasibility studies in both pigs and sheep, and we decided to move forward with the sheep. The anatomy I will show you is quite similar. We've been able to develop a specific hormonal control of the cycle, a kind of pill for the sheep, in order to have control of the oestrus, which is the equivalent of ovulation, to obtain dilatation of the uterine artery exactly when you want for a comparative study. So it's available, it's quite resistant, the cost is acceptable, and it was a suitable model for comparison, even if the initial studies, of course, were done without tumor models. So sheep don't have fibroids. These are the aortogram of sheep. Here, you can identify the uterine and ovarian artery. This is a woman with fibroids, just to show you some similarities in terms of diameters of the vessels and the bifurcations. Selective catheterization of the internal iliac. This is the enlarged uterine artery because of the chronogest methods. That's the patent we had for the hormonal control of the cycle. We also were able to selectively catheterize the ovarian arteries, really like in women with fibroids. This model was published in investigative radiology at that time. The different steps, we had the clinical issues, the animal model. We've been able to obtain gross specimen of hysterectomy, ovariectomy. We were able to conduct MRI studies to precisely assess necrosis. These are the sections before going to the microscope for precise evaluation of necrosis and location of the particles. And from these results, we've been able to change our clinical practice, and I will show you how. First study, 2 types of particles. The reference at that time, non-spherical PVA of different diameters compared to Tris-acryl microspheres developed at Lariboisière Hospital when I was a resident, at that time belonging to a company called Gerber Biomedical, and then subsequently an American company. At that time, nobody was interested in this product except physicians from Lariboisière Hospital where I was working. So the different diameters available. The hormonal control, very important to have comparable animals with the same size of arteries. Super selective bilateral uterine artery embolization, sacrifice, MRI, and pathology 5 days after the initial embolization. These are the gross specimen of resection. This is the score of necrosis with the different areas of the uterus, from the endometrium, myometrium, serosa, transmural necrosis, and the different ways to evaluate, quantify necrosis. First results, if you look at the Tris-acryl microspheres of different diameters, that's what we were expecting, but it was important to verify that the hypothesis was right. If you use very small microspheres, you are going very distal and you generate more necrosis, whereas large particles are associated with less necrosis. And there was a strong correlation. Surprisingly, with the non-spherical PVA, the extent of necrosis was quite unpredictable. Even medium-sized PVA particles were associated with more necrosis than the small sizes, and there was no obvious correlation between the extent of necrosis and the diameter, the individual diameter of the particles. Well, simply because they were non-spherical particles, so kind of popcorn type of products where calibration is quite hazardous. An example of an extensive necrosis using small PVA, transmural necrosis here. If you look at the location and the diameter of occluded vessels, good correlation between the diameter of the microspheres and the diameter of occluded vessels. That's what you expect from a microsphere. But again, this is 15 years ago. Nobody knew really at that time. And if you compare with PVA, again, unpredictable level of occlusion, small and large sizes may occlude an average diameter exactly the same. The reason is given by this number of particles. When you embolize with microspheres, 1 to 2 microspheres are occluding one vessel of the corresponding diameter, whereas PVA is commonly known to be associated with aggregates. And this is an example. Large artery embolized with aggregates, medium-sized arteries, again with aggregates, but at the same time, on the same animal, very tiny fragments traveling distal in the endometrium. So the extent of necrosis is clearly related to the level of occlusion obtained with PVA, which is unpredictable, aggregates proximally, and very distal pieces moving very distal in the endometrium. So it was a big surprise to understand that what we were doing in clinical practice in women with fibroids was clearly not optimal from a technical point of view. We have also been able, when embolizing the uterine arteries with small particles, to diagnose non-target embolization. This is an example with microspheres, small microspheres in the ovaries of the sheep after uterine artery embolization. So as expected in women and reported in women, you may have non-target embolization when using small particles. So conclusion, correlation between necrosis and microsphere diameter, level of occlusion, type of arteries correlated with the diameter of the microspheres. This was not true with PVA particles simply because of the irregular shape and the risk of aggregates, and at the same time, the risk of distal migration of small fragments. These results were published in Radiology. These results were applied immediately to our clinical practice. This is a group of women embolized before surgery or in combination with the surgery. So we had pathology. This was done with different diameters of microspheres. And as you can see, a good correlation between the diameter of the microspheres and the diameter of the occluded arteries was found in women with fibroids. And this is an example. With 500 to 700 microspheres, you can target the perifibroid plexus, which is the ideal target for embolization. So that's what you can get with Tris-acryl microspheres or with other microspheres. You target the perifibroid plexus, you don't enter normal myometrial branches, which are smaller, and you reduce the risk of non-target embolization to the ovaries and to the tubes. So we also decided to change our endpoint. Since you can target the perifibroid plexus, no need to be very aggressive. That's the so-called prune tree appearance or limited embolization, where you only occlude abnormal myometrial branches, but you leave patent the main uterine artery and you spare normal myometrial branches. This is an example. Aggressive technique, small particles, contrast-enhanced MRI obtained 1 day after embolization. You have large areas of devascularization of the myometrium and the endometrium, not only the fibroids. With a targeted devascularization, you can really, again, this is done 24 hours after embolization, you can target the fibroids, sparing normal myometrium and endometrium. And you can nicely see this ischemic necrosis of the fibroids. So the initial experience was published in conjunction with some American investigators for an FDA study, Jean-Pierre being the lead author. Our experience at our center and a French experience with the same technique, initial experience with the use of microspheres larger than 500 microns to treat uterine fibroids. So the results were good. So we decided to investigate the hormonal impact and the fertility impact of such a more targeted devascularization of the fibroids, because it was the next clinical question. Can you treat safely young women? So we decided, using the same animal model, to compare two types of embolic agent, large sizes only, for the reasons I have already demonstrated. We evaluate the hormonal function both clinically with the oestrus, which can be diagnosed by the mating behavior of the animals. And you can also perform biological tests, and progesterone P4 is the most sensitive tool. We compared large sizes, exactly same control of hormonal cycle. And that's the clinical and biological impact. This is a control group. We did only the angiogram, no embolization. This is the group treated with PVA and the group treated with microspheres. Clinical oestrus was reduced after embolization in both groups, but much more significantly after PVA embolization. Biological oestrus, which is diagnosed with the hormones, the impact was lower. But if you look at these curves, there was two things. First, the oestrus, the ovulation peak, was reduced after embolization. That's the blue line here, compared to the control group. And second, as you can see, the oestrus, the ovulation, was delayed by a few days in animals treated with embolization compared to control animals without embolization. If you compare PVA and microspheres, again, significant differences. The peak was lower after embolization with PVA, and the oestrus was delayed by a few days, at least at the first cycle. So there was an impact, even using large particles, with a decrease in terms of number of clinical oestrus and lower progesterone levels associated with delayed ovulation. Again, this is an animal model without uterine fibroids. So the impact is probably more significant on this model than in women in clinical practice, because we were thinking that target embolization was achievable. These results were published as a research letter in the Lancet. We applied this to our clinical practice. This is a group of women embolized with Tris-acryl microspheres larger than 500 microns. And we've been able to identify no change in hormonal levels after embolization using very sophisticated tools, including the anti-mullerian hormone. As you may know, it's a very sensitive tool used in fertility, in the fertility clinics. So no impact of embolization in clinical practice with this strategy of limited endpoint and microspheres larger than 500 microns. That's the publication in Human Reproduction. Third step, so first step, necrosis, understand how you can generate uterine necrosis, non-target embolization. Second, can you reduce the hormonal impact? And the last question, probably the most significant question, what is the impact on fertility? Can we treat embolization, with embolization women seeking fertility? The initial publication were not very favorable. This is the Spanish experience, 19% term pregnancy rate after embolization. The MARA trial in the Czech Republic, comparing embolization to surgery, the delivery rate only 19% after embolization compared to almost 50% after myomectomy, 50% being the accepted percentage of the delivery after treatment. So can we do better? Well, back to our animals, David. Same protocol, comparative study, large sizes of non-spherical PVA, large sizes of Tris-acryl microspheres, randomization of the animals to reduce any bias. That's the overall study, and I will quickly show you the results. Overall fertility control groups, half of the animals had angiography, half had nothing. One animal died. It was attacked by a fox. That's, you know, animal research. That's why you have only 19 animals here. 94% fertility rate. After embolization with microspheres, 90%. After embolization with PVA, 60%. If you look at the term gestation, taking into consideration the number of attempts, up to 3 attempts to get fertility, a pregnancy, 79% for control animals, 53% after embolization with microspheres, and 31% after embolization with PVA. And this is the summary with a significant difference between both type of embolization and between control animals and embolization groups. Another important finding, duration of gestation. Gestations were shorter after embolization with PVA compared to microspheres, not significant, but very significant compared to control animals. And no difference in terms of duration of gestation between animals embolized with microspheres compared to control animals. Birth weight, well, clearly showing intrauterine growth retardation after PV embolization. The animals were really, the weight was much lower after PV embolization, and no difference between microspheres and control animals. So 3 impacts: fertility rate, duration of gestation, and birth weight of the newborns. 3 impacts. So even large particles are associated with some impact on fertility, at least on this animal model without fibroids. And non-spherical PVA, probably because of the unpredictable level of occlusion, was associated with a more significant impact than microspheres. These results were published in the gynecological literature. Of course, back to our clinical practice. Preclinical, you think you better understand, you have a new hypothesis, IRB approval, new study with this hypothesis. So a preliminary study in women trying actively to get pregnant. This was the requirement from our institutional review board for a randomized trial. So 16 women, feasibility study. We were able to achieve a 56% rate of pregnancy, so quite similar to what you can expect with surgery, after embolization using microspheres larger than 500 microns, and again, a limited embolization technique. These results were published in European Radiology recently. So this was the big studies on uterine fibroid embolization. That time, microspheres became a reference in terms of embolization product on the market. Many companies started to propose new microspheres that were supposed to be, at least from the FDA or CE mark criteria, 510K pathways, for instance, to be equivalent. In fact, some of these products were not equivalent in terms of behavior. I'm going to show you. Then you had the next generation of microspheres, radio-opaque microspheres, MR detectable microspheres, resorbable microspheres, drug-eluting microspheres. Some of these products from the market and other products that my research group has developed. When you evaluate a device, before using it in clinical practice, especially a microsphere, you need to be sure of the granulometric distribution. Is the advertised diameter the true diameter? Yes, for most of the microspheres. Range 7 to 900. Yes, most of the particles are within this range, no surprise. What about compressibility and elastic recovery? Big question for any type of embolization in the liver, in the lungs, not only in the fibroids. You may have to deal with very soft microspheres. If they are very soft, they may travel more distal than expected and occlude more distal branches than expected, potentially associated with more necrosis than expected. Conversely, rigid microspheres are traveling to a vessel of the same diameter. That's the case of the Tris-acryl microspheres. Most of these results evaluating different products, independent evaluations from our research group, were published in JVIR or in CVIR. We also evaluate drug-eluting beads, for instance, drug-eluting beads loaded with ibuprofen to treat the uterus. The initial results were encouraging. Our clinical studies stopped quickly because of the lack of advantage demonstrated. We've been able, however, to demonstrate a reduced inflammation, local inflammation, and we've been able to better understand the degradation of other types of microspheres. We have also worked on radio-opaque microspheres. These are microspheres that you can see precisely when injecting them. Some of these products are commercially available from other products are available. This is one of our devices, long time ago, iron oxide loaded microspheres. You can see on this kidney the distribution, again, pathology. This is a kidney of a pig. The same microspheres used in the liver. Of course, the susceptibility artifact is the criteria we use for detection in vivo. So T2 star images here, nicely demonstrating the different areas of embolization. And this was published in JVIR and this one as well. So that's the end of the first part. Second part is more work in progress. But again, as David told you, we have a special interest in HHT patients. And I've been lucky enough to meet with your former professor and chairman at Yale. So I was involved in the management of pulmonary arterio-venous malformation from the beginning of my fellowship. As you know, pulmonary AVMs are abnormal communications between pulmonary arteries and veins, often asymptomatic, but potentially associated with terrible major complications, mainly neurological complications by paradoxical emboli. So stroke, TIA, and brain abscesses have been reported. Respiratory symptoms may also occur depending on the number and diameter of these malformations. As most of you may know, especially at Yale, more than 70% of these patients are suffering from the Osler-Rendu disease, hereditary hemorrhagic telangiectasia. And you have different types of involvement and different types of angioarchitecture. And this was mainly reported. This is an example of a brain abscess for the initial diagnosis of this tiny malformation of the right upper lobe treated with coils. So coil embolization is the reference technique that was popularized by Robert White, really one of the pioneers in our field and one of my mentors as well. He reported the technique, the improvement in the technique. He reported the different mechanisms associated with reperfusion, true recanalization, missed side branches, incomplete sac retraction, and some of the pictures when we were together very young and handsome, as you can see here on this picture, at one of the numerous HHT meetings we attended together. So this is an example of what Bob was showing at meetings. This is an embolization that is not good. Central recanalization, the patient is still at risk of paradoxical emboli. Why that? Well, mainly because the reference technique was fibered coils. And as you know, fibered coils may be associated with recanalization because they generate thrombus, and thrombus may be resolved with time. So I will quickly show you how we try to improve our technique using a new type of coil. These coils are very famous in the field of neuroradiology, hydrogel-coated coils. This is a platinum coil loaded with hydrogel that will expand with time. So theoretically, the amount of thrombus potentially associated with recanalization, the amount of thrombus should be reduced. So we decided to investigate using an animal model, again, of the lung, but also of the kidney and the internal iliac arteries as well, to better understand the initial mechanism of occlusion between fibered coils and hydrogel-coated coils. So the number of coils, the time to occlusion, these are the different parameters. I will show you this first, the anatomy that you know, the renal artery that you know, and the lungs. On the same animal model, you can perform embolization of the different territories with different diameters of vessels and different flow characteristics. The common findings with all these territories are the following. When you embolize with fibered coils, surprisingly, at pathology, up to 70% of the occlusion is related to thrombus. That's why you have fibers on the platinum coils to generate thrombus. But look, 70% is a lot, and thrombus may go away by physiological fibrinolysis, potentially leading to recanalization. With hydrogel, as you can see, the amount of thrombus was 40% only, significant difference, and you have much more embolic, regardless of the type of coil, 035, 018, regardless of the anatomical territory, renal arteries, internal iliac arteries, or pulmonary arteries, exactly the same findings. So that's the main issue. Is it this huge amount of thrombus, this very different mechanism of occlusion, is it associated with long-term recanalization differences between the two types of products? First study was published in CVIR. Second study, long-term. We want to know, is this the initial difference leading to more recanalization? Same model. I show you the pictures. At 4 months, 80% of the arteries, this is, I'm presenting only the renal and internal iliac here. 80% of the arteries embolized with hydrogel coils were occluded versus 25% of those embolized with fibered coils. Theoretically, with the same technique, packing, optimal choice of sizes. In the renal artery embolized with 018, the difference was quite striking, probably less significant when embolizing with 035 coils. So macro coils are less associated with recanalization than micro coils, which is quite commonly accepted in our field. So an example, embolization with hydrocoils of the internal iliac artery. That's the 4-month complete occlusion, some collateral vessels here, but the main vessel is fully occluded. Very nice picture. This is the gel. This is some thrombus. No evidence of recanalization. Long-term occlusion is achieved. The same type of coils, but except that they are fibered. At 4 months, you have some recanalization at the center of the coils because of some resorption of thrombus in the middle of the coils. This difference was quite significant. As you can see, 20% recanalization rate with hydrogel-coated coils overall, 75% with fibered coils, theoretically used the proper way. We all know that microcoils are more commonly associated with recanalization. So when it's feasible, I'm speaking of vessel occlusion, not aneurysm occlusion, you should favor macrocoils because they are less likely to recanalize than microcoils that are very soft. These results were published recently in GVIR. Back to our clinical practice. We obtained ROB approval for a protocol of treating PAVMs in women, in men and women, sorry, these are not fibreds, these are PAVMs, using hydrocoils only, mainly HHT patients, as you can see. These are the results. Recanalization, true recanalization documented by CT and angio, 2% only, which is lower, although not comparative. It's not a randomized trial, I admit. This is the initial experience. 2% true recanalization with hydrocoil, which is 4 times less than what we reported with our patients embolized with fibered coils in the past. So I think this is another demonstration that you can improve your technique when going back to preclinical evaluations. So to summarize, from bench to bedside, as you are, we all work in academic centers. I think we are lucky for that. We have a busy clinical practice that allows us to conduct good quality clinical research, retrospective initially, prospective, ideally randomized. With this clinical research, we can identify factors associated with failures, recurrence, and complications of what we are doing in interventional radiology. We should think of ways to improve our technique. So we should rely on in vitro evaluation, as I show you for microspheres. Compressibility is crucial. Granulometry is crucial. That's already in vitro evaluations. And then in vivo evaluation using appropriate model. For liver work, as you do, we use the VX2 rabbit model. For lung embolization, we may use pigs. For portal vein, we use pigs. For uterine artery embolization, we use sheep. It depends on what you are evaluating. Then you compare on these animals the different hypotheses, technical hypotheses that you have. You can refine your technique, and with this new technique, you can go back to clinical research and then to clinical practice when your hypotheses have been verified on large number of patients. So that's what I wanted to share with you today. I've been lucky enough to work both in a research lab, get access to animals, to microscopes, and in the clinics at the same time. And I think that's the best way to improve yourself for the benefit of your patients. I would like to thank you again for your kind attention, and I think we have some time for questions. Thank you very much again.
Thanks, Jean-Pierre. That was a really awesome presentation. Clearly, what I liked about it so much was that the work that, this was a great literature review, but at the same time, it was a review of your literature. So, so basically you were on pretty much every, at least with the fibroid part, you are on like literally every paper that you presented, which is quite amazing. So there's a number of questions, I guess. Some of them are ones that I also have. One of the things that we're always wondering is why, for example, fibroid embolization has kind of plateaued. And, there's so many women that could get this, but the gynecologists still don't even put this in their when you go to their office, it's not even listed in a brochure that they have about treatments for fibroids. So how does one like change that practice and have gynecologists actually refer patients for this kind of procedure?
Well, that's obviously, David, as you know, this is not only a medical question. This also has to do with a tough battle between specialties, at least in Europe. The way we have approached the question was to go back to science and to publish good quality data. And as you know, we've been almost forced by gynecologists to conduct randomized trials that they don't even have for their own procedures sometimes. And that's what they agree on. Despite having good data, and you have seen this paper in the New England recently comparing myomectomy to embolization, showing that both treatments are equivalent. And this study coming after the Dutch trial and the UK trial, showing that embolization was also equivalent to hysterectomy. So theoretically now, all gynecologists worldwide should offer the possibility of embolization to any patients with fibroids, symptomatic fibroids, potentially candidate for hysterectomy or multiple myomectomy. And we also start to have data suggesting that even in terms of fertility, with refined techniques, we may have a minimal impact on hormonal function and ovarian function. So I don't know what to say. We have now all the data. We've been treating all of us women with fibroids for years with good results. And the number of referrals seems to be, as you said, quite the same for the last years. So I know that in some European countries, you have now some legal issues. Some women not been offered embolization as an alternative to hysterectomy have sued the gynecologist because of the lack of information. So I don't know if that's the kind of situation that happened in the US, but it happened in Europe. That's very sad. I mean, to have this kind of issues, to have potentially the number of cases growing, but that's the way it is.
That's interesting. Yeah, so the technique is so well refined now. I mean, where do you see, I mean, these are more questions. Where do you see the opportunities for research in this field in terms of, technique? And I mean, we've already kind of discussed the clinical aspects of it, but in terms of technique, I mean, is there any way to improve it, or is it basically all done?
Fertility is the key. We are still all of us stuck because of the MARA trial. The MARA trial is the randomized control trial, the first one comparing embolization to myomectomy that was published more than 10 years ago now. With the results I have demonstrated, very bad for embolization. In fact, lot of bias in this study. Technique was not refined, small microsphere were used. Criteria for secondary intervention after embolization were not logical as well. So full of bias, but all gynecologists are still discussing, well, we have the MARA trial, it's bad for embolization. So we need large-scale study. And I was really hoping that, SIR, CSA could, through a joint effort, try to build such a trial, because that's the only way. That's the last field. And that's a big field because, some women are very, very poor surgical candidates. But as soon as they say, oh, I want a baby, even now, most gynecologists will say you cannot embolize. Even when it's, a risky surgical procedure with bad results because you have 50 fibers, because they will open the endometrium, which is bad for fertility. So that's really the field where we need more data. And that's what we are all of us trying to do. The New England trial was mainly focusing on outcomes, not on fertility. The recent one on myomectomy versus embolization. So fertility is the key. And
Great.
that's a
And
very
so
ambitious project.
there's some other questions, a little bit different topics. So this one's actually on leadership and on being like the, I guess, leader of a group where you're obviously highly academic. So I guess the question becomes, as the chief of a section, as the vice chair of a department, do you have expectations for faculty and or trainees in terms of expectations in publishing, doing research, academic pursuits?
Of course, of course. We work at an academic center. So for instance, it starts at the end of the residency to be recruited as a fellow. The minimum requirement is to have a Master of Sciences here. So it means that you need to have at least 2 publications. If you have this, you have a good chance to become a fellow. If you don't have, there is a classification of candidates. You are less likely to get a position because fellowship here in Europe are slightly different. Part of your practice is academic. You are supposed to work with the students. You are supposed to go to the medical school to teach as a fellow. So of course we have expectations. Then I'm also a member of a research group, CNRS affiliated. So that's the National Center for Research, where we have high expectations because, the budget, the funding depends mainly on the number of Master of Sciences that we have, the number of PhDs that we have, the number of postdoc students we have, and of course the number of publications, trials and funding. So everything at the same time. So I think it's good to have, that's my practice at the moment, both a clinical and preclinical, clinical and academic practice. Because with these interactions, I think you are more likely to motivate young people, to follow you and to explore these tracks of research, preclinical and clinical.
Oh, great. So there's also a question about, can you say a few words about reimbursement in France? What are the benefits and drawbacks of a public option healthcare system? I mean, as you know, there's been a lot of, for years, there's been a lot of questions about socialized medicine in the US and how that's going to work. And I guess there's some interest in what's been going on in Europe and I guess France in particular.
Well, that's a good question. We may need 2 hours for that. I don't know if you have time. No, to be serious. I think it's good for the patients, obviously, because regardless of, private insurance, because most patients have additional private insurance, but you can be treated without paying virtually anything, which is good. I mean, liver transplant, you can get liver transplant without paying any euro, which is quite unique. Conversely, the system is exhausted. I mean, we don't have enough funding now. You need to keep the money to treat patients rather than for research. And you have heard all these, protesters in France, all these strikes in hospitals, because the way you can work now are not good. So the system is good for patients. It's not that good for doctors because of the shortage, in staff. It's very difficult to change your equipment. It's very difficult to fund clinical research now, much more than in the past, simply because we lose a lot of money for just clinical care, daily care. And that's the same budget. That's the problem. Otherwise, in terms of reimbursement of medical devices, we're quite lucky because all these devices are reimbursed independently from the procedure. So like we have a specific code for each procedure, but it does not cover the implanted devices that can be charged additionally. It means that we get access potentially to more devices than you, because if I use this type of coil, if I use 10 coils instead of 1, I will be reimbursed for 10. Whereas other systems may consider, global reimbursement for a specific procedure. So different system, some benefits, but at the moment, a lot of drawbacks as well.
Thanks. That was a great answer. So we have one more question, but I think, in the interest of time, I'd like to ask anyone else and maybe one or some of the panelists if they have any questions, because we do have only a few minutes left. Otherwise, I can ask the last question. But does anybody have any additional questions for Jean-Pierre?
I have one.
Oh,
So
okay.
Jean-Pierre, I'm not sure about your practice, but in I think many practices for pulmonary AVMs, people have really, I think, moved towards plugs as opposed to coils, right? And the clinical data, which we have more robustly for the AVP, is quite good. I mean, I can tell you off the top of my head, 4 papers, 0, 0, 0, and 7% recanalization rates. So in my own practice, I really push to use plugs when technically feasible. It's not always technically feasible to put a plug in. And I'm not sure how well you've compared that and what you're doing in your own practice now for your pulmonary AVMs. You're using hydrocoils, you're using plugs, and have you gone to the lab with these and looked at them?
Good question, Jeff. Good to see you. My only concern at that time was the lack of long-term data with plugs. I mean, on occasion we use plug, as everybody does, I would say. But the initial data were only short-term data. So I was still convinced that coils were probably more logical to use. And because of the limitations of fibered coils, that's why we started to work on hydrogel-coated coils. I think the main interest of coils is that regardless of the angio-architecture of the PAVM, you can always use them. Short neck, angulated, multiple feeders, short landing zone. You can play with coils in a very flexible way compared to plugs. But I agree with you. I mean, on occasion, we even combine plugs and coils, to go faster, but potentially to be safer with a large plug, and then add some coils after that. So I think we don't have a lot of data with any of these devices simply because it's a rare disease. You and me are familiar with that because we love to treat these kind of conditions, but the literature is still very limited overall. But I agree. I mean, from a technical point of view, you have the choice, and randomized trials or comparative trials will be difficult to conduct anyway.
Okay, anybody else? So I think with that, we probably should wrap it up. And I want to thank you again. That was really great. I mean, like I said, having somebody that has written a large portion of the literature on a topic and being able to share it with our faculty and trainees is really, really awesome. So I think we'll end here, and thanks again, and we will definitely be in touch.
Okay, thank you for the invitation. Bye-bye.
Thanks.